Hi everybody, today I want to start pharmacology of antidiabetic drugs. Diabetic mellitus is one of the most important diseases which are related to the pancreas and insulin. And pancreas has two parts, exocrine and endocrine part. In the exocrine part, we can say they produce digestive enzymes from the acinar cell. And also there is a ductus cell which production of the bicarbonate for neutralization of the acidic which comes from the stomach. But in the pancreatic islet cells, which is related around 5% of the mass of the pancreas, there is a 4 type of the cell. Alpha cell, which produce glucagon and proglucagon. Proglucagon is in active form of the glucagon, which helps to increase the blood glucose of blood. And the beta cell, which produce insulin, usually for production is the proinsulin first time, and amylin. And the delta cell, which production of some somatostatin, and PP cell or F cell, which production of the pancreatic polypeptides. Today we want to study about beta cell, which is mostly important about diabetic mellitus. Diabetic mellitus, we can classify diabetic mellitus mainly in 2 types. First type is the type 1, which is the no production of insulin. And the second type, which insulin is production, but resistance about insulin is very important. Also, there is a type 3, which is related to the gestational diabetic mellitus, which is in the pregnancy time, is also important, and it can be very important. And usually type 1, it is in the young age or in the childhood times, which is usually because of the antibody or autoimmune disease effect, because it attack for the beta cell. But type 2, as in insulin resistance, can be because of in the old age or in the middle life of age, for example after 40, 30, because of the diet, and also because of the other problems which can cause insulin resistance and this type of illness. And both of them, for the treatment, we have 2 possibilities. First possibility, the pharmacology, drugs. And the second possibility we can use, we have to control the diet. Also we can fasting, and also we can control and check the hemoglobin A1C, and also the blood glucose. Usually before I start the pharmacology of the diabetic mellitus, I would like to explain about insulin. Insulin, when it's produced by the beta cell, it is proinsulin, and it has 86 amino acid. As you see in this structure, they has 3 parts. R chain and the B chain and the C chain. This is proinsulin, which is in inactive form. Okay? The reason of inactive is because of the C peptide. Okay? In C peptide, when we remove the C peptide from proinsulin, then insulin with R chain and the B chain with the disulfur bridge between two cysteines, which is in the R chain there is a intra disulfur bridge between two cysteine, and the B chain there is a two disulfide bridge between two cysteine between the R chain and the B chain. And when we remove the C peptide, then proinsulin convert to the insulin and will be active. Insulin can affect in the liver, skeletal muscle, and adipose tissue to transfer of glucose from blood to the cells. In this situation, and it can be helps for decrease blood glucose. How the mechanism of the insulin? Okay, the first part I would like to explain how the insulin is released from the pancreatic beta cell. Okay, when the blood glucose is increasing or high, this blood goes from the glucose transporter, which is said GLUT2, which we will speak about it later. Okay, in the beta cell, metabolism start and the glycolysis happen and the glucose convert to the pyruvate, and this metabolism increase the production of the ATP. ATP can go and activate potassium channel, okay, and close or depolarization happen. Okay, in this case, intracellular will be more depolarization, and because of this depolarization, calcium channel open and the calcium come inside the cell, and the calcium, one of the reasons of the exocytosis of the proinsulin from the beta cell, and in this case proinsulin will go out. As you remember, I spoke about the GLUT2, which is we can find in the beta cell of the pancreas. We can find also the liver, kidney, and the gut. This is one of the important things we have to know about the GLUT2. And it is very important because, as you see here, in the GLUT2, we see it is regulation of the insulin release and is aspect of glucose homeostasis. And also there is other GLUT, for example, it affect in the GLUT3, we can find in neurons, it is insulin dependent. And also there is a GLUT5, it is in the GI, which helps to absorption of the fructose. Is very important. It's not work with the insulin. And also GLUT1, also it can affect in the blood-brain barrier. It is insulin dependent. As you see here, these types of the GLUT is not insulin dependent, but GLUT4, which insulin mediator update of the glucose, is very important, is insulin dependent. And in the diabetic mellitus patient is very important, this type of the GLUT. If we see the structure of the insulin receptors, in the insulin receptor we have a tyrosine kinase domain, which there is an area which can be activated to convert ATP to ADP. And in this case, there is also alpha subunit, okay, and the receptor which insulin molecule can bind for that part, which can cause activation of the beta subunit. It can cause the dimerization, and after phosphorylation and activation by the ATP. In this case, this insulin receptor can be activated, and the mechanism of the glucose uptake will be start. How the insulin regulation start? How we can regulate insulin production and synthesis and releasing? For example, the first important things is the intestine. After we feed, the glucose increasing. When the glucose increasing, in this case, it can cause effect in the beta cell in the pancreas. And in this case, insulin will be increased by the GLUT2, which I explained it. Insulin can affect in the liver. It can increase the absorption of the glucose by the liver. Then liver start 3-4 more mechanisms. One of them is the glycogenesis, making glycogen from the glucose. Okay. And also it can helps for the transfer of the product for the adipose tissue, or uptake of glucose by the adipose tissue and the muscles. Now we go to the next steps, which what happen if no insulin working or not we have the mellitus. For this mechanism, I start to explain of the insulin in the liver. As I mentioned, it start glycogenesis, I mentioned, and also it inhibit glycogenolysis. Glycogenolysis mechanism which glycogen convert to the glucose. This mechanism will be stopped. Okay, the other one, conversion of fatty acid, inhibit conversion of fatty acid to amino acid, to keto acid, and amino acid to keto acid. Inhibit conversion of amino acid to glucose, which causes gluconeogenesis. It is important, and what I mentioned before, it also important for the glycogenesis, which production of glycogen. And also anabolic action, we also promote glucose storage in the glycogen. I say glycogenesis. And also inhibit phosphorylation, increase triglyceride synthesis. And it can transfer by the VLDL in the circulation, we will see in the later lectures, to LDL, and the transfer of the TG to the fatty acid to the adipose tissue. And also affecting the muscle, it can increase protein synthesis. It is the anabolism. Increase amino acid transport, increase protein synthesis in the ribosomal, increase glycogen synthesis, glycogenesis from glucose, increase glucose transport from the blood to the muscle, increase glycogen synthesis, inhibit phosphorylase, and inhibit glycogenolysis. And also it can affect in the adipose tissue, as I mentioned, when the LDL or VLDL transfer the triglyceric acid to the blood, then fatty acid goes inside the adipose tissue, then increase, and we have also glycine formation, both of them, glycine, glycerol or glycerin, they both can help the formation of the triglyceride. And the lipoprotein lipase helps for the activation of insulin to hydrolyze triglyceride from the lipoprotein, as I mentioned, LDL and the VLDL. Okay, by help of the lipase, it can release triglyceride to fatty acid and the glycerol. Glycerol can go to the liver, but fatty acid can go to the adipose tissue. Glucose transport into the cell provide glycophosphorylation, promote esterification, and fatty acid synthesis inside the adipose tissue, and also intracellular lipase is inhibited by insulin. Now we start the pharmacology of insulin. Pharmacology of insulin is very important because in the pharmacology of insulin we want to know what type of insulin we can have, and this insulin is very important. Before this, I would like to explain how we can know the patient has a diabetes mellitus, for example, hemoglobin 1A, A1C, if the amount is more than 6.5%, or fasting glucose bigger than 7 millimole per liter, okay, or 2 hours plasma glucose after eating, it becomes more than 11.1 millimole per liter, and usually high amount of this glucose can be sign of the diabetic mellitus. And it's very important we have to know about which type of insulin we use. For the control, we use a special device for the control and measurement of insulin every day. But for the using of the insulin, we use insulin analogs, which has a just R chain and B chain. Insulin also is a doping in the sport. And how we can know, we can measure about C peptide. If we know the relation between the ratio of the C peptide and other part of the insulin is not the same, in this case we can understand the person used insulin, because in the insulin drugs, they don't have the C chain, and also as always it hasn't C peptide. It's very important because these what is the difference between the physiological insulin and drug insulin. The physiological insulin is a proinsulin, has a C peptide, which is when it becomes active, it will separate, and the C peptide we can measure in the blood. But in the drug we don't have this part, and it's very important. The type of insulin which we use is very important, and we have to, as I mentioned, when the glucose increase, we have to use insulin, usually in the type 1 diabetes mellitus, because in this case the patient hasn't any production of the insulin. And after we can classify it in the 5 type or maybe more depend for the type of classification. We can classify rapid acting insulin, short acting insulin, intermediate acting insulin, long acting insulin, and insulin delivery system usually we use for the type 1 diabetes mellitus. And there is a many factory which can they produce the this type of the insulins. As you see here, if you see time in per hour, when we have insulin for example Lispro or Aspart or Glovin, they are usually has a very fast acting, and they are short acting, and we can use a regular insulin. It has effect in the 4 hours and a little high in the duration, and the MPH it has for the regulate insulin the blood we can use, and we can use insulin detamide and insulin glargine, which is they can be has a long effect. It's very important when we use this type of the insulin is very important, okay, because mainly we can use after the for example breakfast or lunch, we can use Lispro, because in that time the amount of the glucose is very high, and we can control we can decrease the glucose very fastly. But later we can use other type of the insulin, okay. And usually for the patient we need combination of these 3 type or 2 type of insulin. Usually we use short acting with the regular. For example, some patients use Lispro with regular insulin, or Aspart with regular insulin. It is very important, and we can also control the blood with also other drugs, which I will explain later. Also, we have a long-acting insulin like glargine. It is a short, also slow onset of action, usually achieve a maximum effect after 4 to 5 hours. This maximum activity is maintained for the 11 to 24 hours, as we see, and it is used to provide reproducible and convenient background and of insulin replacement. Glargine is usually given once daily because it is for the maintenance of the blood glucose, and insulin glargine result is less hypoglycemia and has provide a better once daily in 24 hours, and also we can use insulin detamide. This type of the insulin detamide has a fatty acid side chain, which is the proline and availability of injection analogs by the increasing both self-aggregation in the C tissue and the reversible albumin binding. In this case, this type of the insulin has a dose-dependent onset of the acting after 1 to 2 hours, and duration of the action was more than 24 hours. And it is given twice daily to obtain its most background of insulin level. It's very important. And also we have sometimes very long, ultra-long acting like degludec, which is very important. Also, it can be effective so more time, and just for ultra-long time, which is very important. And usually we can give in every second day from this treatment. As you see here, insulin can have a high side effects. The main side effect is hypoglycemia. It can decrease the glucose very fastly. It can cause a coma, and if damage in the brain neurons and the brain cells. And for this reason, it is better we control the blood by the device. And it is very important. Insulin-induced immunological complications sometimes also happen, but rarely in this condition, and it is better we try to regulate insulin, and we have to, in every month, we can measure hemoglobin A1C, and other things also. Maybe it can affect in the injection area. It can cause a problem in the injection area, and also sometimes some patient also can be allergy also happen, but it is rarely, and sometimes it can cause insulin resistance. It is also mainly important. Also can be causal lipohypertrophy, and also effect of injection place is very important. And now we go regulation of insulin release, and the physiological background of this part is very important. Stimulation of insulin release can be caused by the high amount of the glucose, mannose, or leucine, also, or the vagus stimulation of the parasympathetic nervous system. Okay, it can be caused by the sulfunylureas, which is important. This can cause stimulation of insulin release. It is a drug. I will speak about it later. And amplifier of glucose-induced insulin release. For example, enteric hormones, glucagon-like peptide, gastrin-inhibitory peptide, GIP, cholecystokinin, and secretin, and gastrin. And also we have a neural amplifier like a beta androreceptor stimulator, amino acid like arginine. And inhibitor also we can inhibit by the neuron system like a catecholamine, as a sympathomimetic effect on the catecholamine, and also hormonal, which I spoke about before, somatostatin and the amylin can be inhibited. And drugs also inhibit the release of insulin, the diazoxide, phenytoin, vinblastine, it's for anti-cancer, and colchicine is very important for the inhibit insulin release. And insulin secretages is very important. This type of the drugs can closure of the potassium channel, it affecting the potassium channel which in the beta cell. Okay, the family of the drugs are sulfunylureas, for example, tolbutamide or tolbutamide, or chlorpropamide and glyburide and glipizide and glimepride. And this type of drugs is very important of this classification. They affect in the closure of the potassium channel and affect in the release of the insulin. It increases the release of insulin. And toxicity can cause hypoglycemia, allergic reaction, and also weight gain. It's very important. Okay, non-insulin antibiotic drugs is very important. The first group we studied about insulin secretages, we studied about it. And also we will start, the second group is the B-guanide. Metformin is one of the important drugs. Usually we use it in the hair mainly. And also we have a thiazolidinones and also alpha glucosides inhibitors. These four types of the drugs is very important. Okay. And these types usually is used. We use for the diabetic mellitus type 2. For example, we see here sulfunylureas drugs and how we can classify it, how the structure. See, they have a side chain and it has usually aromatic side. cycles. And for example, tolbutamide, if you see here, or uronase, it's one of the important drugs. It mechanism action, it increases the secretion of the insulin from the beta cells. It affects for the potassium channel. It can affect in the SUR protein. Okay, and it affects in the potassium channel and increase the release of the insulin by the exocytosis. Okay, because in this case, when it binds to the SUR1 protein, in this case ATP can bind for it, and it closure of the potassium channel, and positive charge inside the cell increase, and then it can cause exocytosis very easily, and it's very important. Usually they increase the release of insulin to type 2 mellitus. It can cause hypoglycemia also, and this drops. And also we can have a other example, and the duration action can be different, if, as you see here, in the usually around 1 day. And this type of the drugs, we can classify the first generation and the second generation. And the first generation is the tolbutamide, and also tolazamide, it is the first generation, and chlorpropamide is the first generation, and other drugs are the second generation. Okay, what is different? All of these drugs can absorption very well. Okay, and they can, all of it can be metabolized, and okay, and usually tolbutamide metabolite is inactive, but tolazamide is the metabolized is active form, and chlorpropamide is active form, metabolized in active form, and also the others those metabolized active form. Just tolbutamide, the first one metabolized in action in inactive form. Because of this, the dilution action is very low, and also usually after metabolite they secreted by the urine, and then we can test in the laboratory in the urine test also. And mostly the problem of this group of drugs, it just can cause hypoglycemia, because increase the release of the insulin is one of the important mechanism of this group, can cause hypoglycemia, and also can be other problems, can be also, it can affect impair hepatic and renal function, because it is because of the metabolites and release, and also this type of the drug can cause increase the body weight. Okay, because it is also important, because it can cause increase the weight of the patient. It's very important. And this one we study about this, mainly it is can enough for about this group. As I mentioned, it can be, I spoke about the first generation and second generation, and also as you see here, the structure of the meglitinoids and is very important, and we can see repaglinide and nataglinide is very two drugs which has a short acting effect, and we go to the next group is the bioguanides. Also the most important drugs of this family is the metformin. They are insulin sensitizer. Okay, it increases the sensation of insulin, and the metformin is the only drugs which are related to by guanides. And there was other drugs, the fenformin is withdrawn in 1970, and also it has a side effect about the cause of lactic acidosis. Is very important. Metformin can absorption easily from the small intestine, and it has the half-life around 1.5 to 3 hours, and it does not bind to the plasma protein, and it's got unchanged in the urine. We can see in the change, but it can affect the toxicology in the gastrointestinal distresses and the lactic acid in some patients, because I mentioned the other drugs, fenformin, which is withdrawn from the medical. And also mechanism action is very important. Inhibit gluconeogenesis, no production of the glucose. Induction of glucose uptake in peripheral tissue, slowing the absorption of glucose, and the reduction of the glucagon level is very one of the important. We can see in the structure of the insulin also here. Okay. And other groups, it is a thiazolidine dione is other group is very important, and which is very, very important also drug with this. We can see has a two drug, rosiglitazone and pioglitazone. It is a two drugs. It is very important drugs, and mechanism action has increased the target tissue sensitivity and also increase activity of the peroxisome profilation, activation receptor, gamma nuclear receptor, and effect on the PPAR receptor is very important. And they are selective agonist for the nuclear peroxisome profilator and activator receptor gamma. It is, or we can say this one, it is gamma. I'm sorry, it is missing here. The principal response of the PPAR gamma activation in the adipocyte tissue is very important. And along with the adipocyte differentiation, also PPAR gamma activity promote uptake of the circulating fatty acid into the fat cell, and the shift of the lipid store to the adipose tissue is very often important about these drugs. Okay, these drugs is very important because it can affect mainly in the adipose tissue, and it can toxicity, it can affect fluid retention, myocardial infarction, bone fracture, and liver enzyme inducer is one of the important problems. As you see, two type of this drug we can see in here, which is very important, and this drug also has an adverse effect or side effects. Usually for this graph we can say increase the body weight, also weight gain is one of the important side effects, and sometimes it can cause of edema in the peripheral tissue, and also increasing the body adipocyte, and the range of weight gain is usually in the adipocyte is very important things. Also promotes sodium ion reabsorption in renal collecting tubule, and it also can be cause of the fluid retention. It is also very important. Increased fluid retention is very important, also sometimes happen, can be caused in the vascular system. Also it can cause effect in the CHF, and also as I mentioned, edema, or it can be affecting the cardiovascular system is also which is important. And also liver function must be controlled, and also osteopenia in the woman increase the fracture of the bone, also very important. We have to control, which this is, they are very important things. And we have, as I mentioned, this drug is very important. Alpha glucosides inhibitors, acarbose and microlitol is the two drugs is very important. Also we have other drugs that the name is the voglibose, and also mechanism they usually inhibit alpha glucosides, and toxicity it can be affecting the abdominal effect, abdominal pain, diarrhea, flatulence, and everything. This can be cause of this medicine. And the first drugs, as you see, it is acarbose. It can also affect is very easily. In the drug should be administered at the start of the meal. It is one of the important system of the usually it we give for the type 2 diabetes mellitus, and I mentioned it can usually cause diarrhea and abdominal pain. It's one of the most famous side effects. It is very important. And as you see here, acarbose, if you see structure, it is like a polymer chain, and it is before meal usually, or the starting type of the meal is very important. And after meal it can be has the most important problems. And the last group is the miscellaneous drugs. It's very important for us in the last part of the drugs. For example, Paramlitide, Exenatide, and the Sitagliptin, which is effect increase insulin production, decrease hepatic glucose overproduction. It also can be effect for the use for the type 2 diabetes mellitus, and is important because these drugs can affect in the insulin secretion, and it can be affecting the type 2 diabetes mellitus. And this type of the drugs usually used in the combination with other drugs. For example, usually we use combination of these drugs with metformin or other drugs. Usually these drugs has can cause side effect like sweating. Okay, can affect in the feeling hungry, and it can affect in the kidney. And usually the patient has a kidney disease, we don't recommend for this use of this drug because it's very important. It has a very side effect in the kidney also. And as I mentioned, it can control helps for the control of the blood in the group type 2. Now I explained the one classification in this table which can help for the treatment of the diabetes. We can use insulin secretion drugs like sulfunylureas and for example rosiglitazone for the pancreas for effect for the beta cell to production of the insulin. And we can use for the fatty acid output decreasing and glucose uptake increasing, and we can use rosiglitazone and pioglitazone. And also we can use decrease hepatic glucose output or gluconeogenesis with metformin, rosiglitazone and pioglitazone. And also we can use increase insulin increasing creatine effect with the Exenatide and Sitagliptin, and we can decrease glucose absorption but acarbose and microlitol. And also we can affect the glucose uptake increase in the muscle is like rosiglitazone and pioglitazone and metformin. And thank you for this. Pay attention for this course. I hope this course can be effective and good for you. And I hope we can meet each other in the next lectures. Thank you and have a good time.